All right, everybody, good afternoon. Thanks for coming out. Very happy to have Dr. Elise Anderson-Shaw with us today. She has appointments everywhere. She's in the nursing school, the medical school. She's the, I got this thing here, right? The Director of Clinical Ethics Consult Service here. Like if anybody's got a problem, ethics-wise, like this, she solves all of them, okay? Like if you're gonna call, it's not Ghostbusters, it's Dr. Shaw. So we're really happy to have her with us, so please help me in welcoming for this talk today, Dr. Elise Anderson-Shaw.
Uh-oh. Can you hear me? Am I on this thing? Is it working? Thanks. Well, that was a very nice introduction, and I usually don't walk around too much, but I'll walk a little bit because we're a small group here. But I don't really solve people's problems. I wish I was that powerful. It would be great in my own personal life with my kids and things, but what I do is I help people make decisions. So part of the skill set I have is models for decision making, and they're from a clinical background. So my clinical background is that I'm an APN in medicine from many years ago. I probably couldn't pass the test if I had to take it again. But I don't really do that kind of work anymore. Now I do the ethics consult service. So some of you may run into me up on the units when you get on our units at UIC. I consult for RML Hospital, which is an LTAC as well as a vet hospital, and also McNeil is a community hospital near where I live. So I'll tell you a little bit more about what I do for ethics consults and how I work with our education for College of Medicine, College of Nursing. My doctorate's in public health policy, so I do a lot of work for policy. I'm right here in UIC. And then I have a master's in bioethics from Loyola University, which was a long time ago when we didn't have online programs. So the Neisminger Institute at Loyola has a wonderful online program if anybody's ever interested in doing something like that. But I'm going to talk basically about the principles of bioethics today. And these are things that you can keep in your mind when you're looking at your patients, when you're reviewing the charts, when you're looking at the social situation about who makes decisions for their patients. That's a lot of the calls I get, is that we have patients who can't make their own decisions for medical care, and they may or may not have any family members around. They may or may not have a power of attorney for health care where they've assigned a proxy or a decision maker for them if they cannot make their own decisions. And so if they have none of those, then we have to find the legal decision maker. So I work closely with our social workers and our legal counsel for those kind of issues. But we're just going to talk about the basic principles of bioethics. How many of you are familiar with Beecham and Childress' test on principles of bioethics? Well, good. Then I won't have to repeat. I mean, this won't be something that you've already learned before. But we're just going to speak to these principles. Now, UIC, we have, or I guess they change the algorithm every other year. So right now it's UIHHSS, the Ethics Council Service, and then I'm part of the Ethics Committee. So part of the credentialing of Joint Commission standards, which you might have heard of, we rely on the Joint Commission to review our hospital, all the services. There's all sorts of standards that we as an institution have to meet in order to get accreditation. And accreditation is tied very strongly with reimbursement, Medicare, Medicaid, et cetera. So we will always do our very best to keep our accreditation up because it gives some recognition to our institution as being able to provide good care, but it also allows us to get reimbursed for the care that we give in the way that we need to. So the Joint Commission is a huge big deal. So they require ethics committee or some kind of ethics mechanism by all institutions. So wherever you practice in your clinical practicums, or eventually where you will be, they're going to have some form of ethics committee. They may do it very differently. We at UIC, we meet once a month, the first Tuesday of every month. If anybody's interested in being a guest, just contact me. And we also have the consult service. So even though I am the designated consultant for ethics, my committee members are awesome, and they're from all different areas of the hospital. Nurses, social work, chaplains are very important. We try to get physicians from, or clinicians from all of the, like I always call them big ticket items like OB-GYN, neonatal, ED, those kind of folks that are MICU, because they bring in a lot of clinical expertise to the cases that we work on. And so I'll take any kind of consult. Usually, again, I'll talk a little bit about what I do as they come up, but the consultations usually cluster around end-of-life decision-making, or family dynamics decisions about end-of-life, or decision-making just in general. The family needs more information, they're not sure where to go. And I always clump that into the category of goals of care. So that's a nice way of talking about what is our goal for this patient clinically. It may not be the goal of the family that the patient should die, for example, but clinically it may not be the goal anymore, is to cure, or to, so what we have to do is kind of help the family go down this different road, because there's only so much we can do as clinicians, as medicine providers, for healthcare, and the rest then is up to that patient's own ability to use our medicine or not, because we all die, and that's going to happen. But how do we prepare our folks for that? So the principles of bioethics, according to Beecham and Childers. The first book came out in the late 70s, so it's like in its 6th or 7th edition now, and it really is kind of the backbone of what we kind of start learning in bioethics. But it's respect for autonomy, non-maleficence, beneficence, justice, and then there's little sidebars, fidelity and veracity. And we'll go through each of those and how you can apply those to your practice. Principles really aren't theories. It's not like utilitarian theory or a economic theory that has all sorts of principles and sub-principles, et cetera, that kind of walk you through. These are just general concepts. And so that's really helpful when we're making decisions. Sometimes we don't need a full theory of A, B, C, D, E, F. We just need to know a little bit about what's going on with the patients in our practice. The common morality contains a set of moral norms that includes principles that are basic for biomedical ethics. So some of these they're not colloquialisms so much as they are like a common moral kind of precept that we all come into clinical practice with because of our education, because we're in a culture of medicine or nursing or healthcare. So there's some common moralities among our group. And then there are those that are among our patients that we serve. And the principles serve as an analytical framework, again, just kind of out there for us to use and to think about. And I've got some case examples, so for each of the principles, we'll kind of go through a case example. So if you have some examples of your own, I would love it if you could share those with us, because we're kind of a small group, so we can do that. So the very first one is respect for autonomy. It comes from the Greek, which is auto, or self. Self-rule. And it's really looking at self-determination. So our patients come in, and if they have the ability to make reasonable decisions, and there's 4 main things that the patient would have to do in order to allow themselves to be consenters. So there's informed consent, and there's elements to informed consent, and the patient would have to have all of those. But we assume anybody that comes in for our care, unless they are unconscious, has the ability to make their own decisions until we start questioning that ability. When we talk about self-rule, it's free from both controlling interference by others, like us trying to talk them into something. Oh yeah, you have to do this. This is the only thing we can do. You don't have any choices. And from interference by others, but also the controlling issues of a staff. So for instance, if the patient's family is in the room and they're trying to make decisions, they may say one thing in front of the family, and then when they're alone, they may say something different for you, because they want to please their family members, but it may not be the decision that they want to make themselves. So we have to also allow them the education they need to make a good decision, or to make the decision. We have to give them that information, because that would be interference by us if we didn't, right? If we only gave them the information that we wanted to use for this decision, then we wouldn't be giving them all the information for them to make an autonomous decision. So we assume patients can make their own decisions when they come in. What happens is when they start questioning things like, oh, I really don't want to do this surgery, or I don't want to have this procedure. And in the clinical mind of the team, it's that they have to have this procedure because we can't find out the treatment until we know what we're dealing with, but they refuse. And then we start thinking, well, maybe they don't have the full capacity to make their decisions. And that's when they call psychiatry to do an evaluation, or they'll call me to help. Who's going to sign consent? What if it's an emergency? Those kind of things. So here's an example, and then we can talk about this one a little bit. I had a patient several years ago, 75-year-old woman who comes into the hospital, and she's complaining of discomfort and pain. She was soon diagnosed with cancer. And the daughter, who was at the bedside continuously, talked to the team prior to them disclosing her diagnosis to the patient, and said that she didn't want her mother to know what her diagnosis was. And she was very clear. She said, I don't want her to know because then she'll get depressed and she won't know what to do and she won't be able to make a good decision. I'll make the decisions for her. And the team tried to talk to her and say, well, she can make her own decisions. She's able. She came in. She talked to us. We really believe that she has a right to make her own decisions. And she can't make a decision about treatment if she doesn't have all the information about what's going on with her. And the daughter was very, very, she was just like, no, you can't. This is my mom. I take care of her. But she could take care of herself. She did have some failure to thrive. She had lost a lot of weight and that kind of thing. But it turns out they lived together. So she really felt very, very protective of her mother. The patient was alert, oriented, was ambulatory in the bed, in the room. And so they called me and said, what do we do when this happens? We don't want to make this daughter angry and have issues with the care that we give her mom, but we think that the mom should have the right to make this decision. So I went out to the unit and talked to the daughter, and again, she was very protective and said, my mom, I'll make the decisions for her. And I said, but that's not, really the right thing for us to do here. The right thing, is to let her make her own decisions. So what we ended up doing, anybody know what we ended up doing? How would you deal with something like this? Yes?
If maybe there was some context of it being a cultural expectation, can you talk to the patient and ask them if they want to know?
You hit it on the head. So what we did was we went into the patient's room. We had witnesses. It's always good to have a witness just to kind of make sure that we're hearing the same thing at the same time. We asked that the daughter not be in the room when we talked to her. And the physicians told the patient, she said, we have information. We have the diagnosis from your tests that you had. And we would like to share it with you because there'll be some decisions about your treatment. And we would like to know if you want to know, or if you prefer your daughter knows, and she can help you with these decisions. And the patient was very clear that she said, I want my daughter to know. I don't want to know. So that we were still really uncomfortable with that scenario, but it turns out that it worked well. And that this is probably the way they had lived, and their environment or their relationship was such that the daughter probably made a lot of the decisions. So that's part of the culture of the family unit. But we also have the obligations that come with what we do in clinical practice. So that's how we came up with that, and we all we documented, everybody documented the conversation very well, and that was probably the best outcome we thought we could come up with. But again, families come to us, or patients come to us with different kinds of expectations, and maybe the expectation was that my daughter will do this, but we had to find out. So that was one of the cases what we had with respect to having a patient make their autonomous decisions. Does anybody have any questions or ideas on autonomy? In Illinois, and keep that, if you have one, keep that thought, you have to be 18 or declared a mature minor. It doesn't mean that we disregard teens, like especially 15, 16-year-old people who can reasonably, look at things and often be able to participate in their decision making. But the law says 18 to sign consent. We often ask for assent, but when you ask for assent, yes means yes and no means no. So if we're not going to give them the choice, then it's really interesting to ask them if they want it, and they say no, then what do you do? So those are those issues with autonomy. But we can provide support for families if they need to talk about these things with their teenager. Because if you ask the little kid if they want a shot, they're always going to say no. No. So any other thoughts, and I won't interrupt this time, I promise, about autonomy? Yes?
I guess it's kind of a weird case, but what if someone wrote like, what are those things called? Just
Advanced directives.
advanced directive, that's the word I'm looking for.
Perfect.
What if someone wrote an advanced directive, like let's say 10 years back,
Mm-hmm.
and now they're unconscious, and you're like, oh, here's the advanced directive. But then the husband comes along and he's like, no, like my wife would definitely not want this procedure, but in the advanced directive it says I would want this procedure.
So is the husband the power of attorney according to the advanced directive? Is he the decision maker if she loses capacity? Let's say he is.
I guess let's say he is. Like
Yes,
in this-
okay.
in this,
So the power of attorney for healthcare is a legal document that does not have to be notarized or filled out by an attorney. But you can pull this off the Illinois Department of Public Health. It has a brief. It's a statutory short form, basically. And that's where you can name a person if you should lose the capacity to make your own decisions. Let's say you come in and you've been in a car wreck and you're unconscious. And it only can be revoked by the patient themselves. So if they come in with a 10-year-old form and it looks legitimate, and they've named the proxy as the husband, let's say, and there is a spot, there's several spots in the paperwork itself that you can add some information. So let's say you added the information somewhere on the form, you wrote it in, you initially that you never wanted to be placed on a ventilator. That would be, you could say I'd like a time-limited trial, but if it looks like I'm never going to get off the ventilator, then just take me off. So in this case scenario, let's say the patient came in, she was unconscious, she was very sick, and she was on the ventilator, but after 2 weeks, right around there, they want to put a trach in and send her to a nursing home or something like that. And the husband says, I don't think she'd ever want that. And in that case scenario, you've got the document that kind of they're concordant. But let's say the husband says, oh my gosh, I don't know why she said that. She would always just want to live. My wife wants to live, and she would accept the ventilator even if she never woke up again. But you never know, because someone who was unconscious in Canada was in a coma for 10 years and then they woke up. So that's always the scenario you get. And then the staff gets together and says, gosh, we have this paper that says she wouldn't want X, Y, Z. But we have the power of attorney who's saying, I think she would. So the short answer is we would talk to them, the family, and say, gosh, why would she have written this in her paper if she didn't, tell us about her lifestyle. What did she like to do? And a lot of times they'll say, oh gosh, mom loved to play bingo, she went shopping, she went out to dinner with her friends, she loved life until, she was not able to get out and about anymore. So then that kind of goes back to like, well gosh, if she really liked to do these things and now she'll never get to do those again, would she want to do that? But in the end, the power of attorney can make any and all changes that they wish to do legally. We might have a conversation with them and talk about that, because it may be that they're just not quite ready for that person to die, because once we remove the vent, likely they won't breathe well, and that would be the end result. So we kind of like to get the chaplains in, and we get lots of people in. But good question, and powers of attorney do change what the patient's written.
Quick question, is there a policy, or do you give advice to primary care physicians about appropriate time to talk to individuals about advanced directives?
Well, we're trying really hard right now to get all of that stuff done in the clinic situation. And in fact, under the ACA, there's going to be reimbursement for that end-of-life conversation. Because a lot of docs say, I don't get reimbursed for it, I'm not going to spend time, it takes a lot of time. But in our clinics, especially, let's say, oncology, transplant, some of the big surgeries areas, we want that to be done and have that conversation. And there's people that can help, social workers and whatnot. But the right time is when the patient really isn't dying to fill those papers out. It's when they're somewhat healthy in the clinic situation with a provider that they trust and know. Our patient population at UIC isn't always like that. They don't kind of have that primary care. A lot of them do, but we get patients that just come in off the street and nobody's ever had a relationship with them at all. But anytime we can have that conversation is better than not. But that's a good question.
So like the majority of us are probably in our 20s, maybe early 30s. Should we have these documents at this point?
Absolutely.
Like,
Because you know the
do we
three
have to get them
main.
notarized?
No, you don't have to get them notarized. They have to be witnessed by someone who isn't your power of attorney and dated. And anytime you want to withdraw it, you just tear it up and throw it out. There's no registry for it. But the three, and then we'll go on real quick. The three cases that went to state and Supreme Court were all 20-something-year-old women. So car wreck, drug overdose, heart attack. So just to bring it home, it's never too late to do that. Okay, you've heard about Immanuel Kant probably in one of your philosophy courses. He was a deontologist, and then we have John Stuart Mill, who was a utilitarian, a consequentialist. And these two things I use a lot with decision making. So deontologists believe, like Immanuel Kant, that it wasn't the outcome that was the most important. So clinically, it's not the outcome, it's how we treat the person during that procedure or that time. And John Stuart Mill was a utilitarian. What's that mean, really? Remember the greatest, what is it?
Ends justify the means.
Yes, so it's the greatest good for the greatest number. It's what we use all the time in healthcare. You think about the bell curve. We want all of our patients to be immunized, all the children in Illinois. So we want most of those folks to come into the middle of the bell, right? But we know there's tails, and we accept that. There's tails that people just, either way they're going to fall off. But as long as we can get the most people in there. So we use that all the time in ICU, for example. We have too many patients and not enough beds. So who's going to get put to step down unit? It's going to be who is going to benefit most from our ICU technology. And the patient that tends to fall off on the curve is going to go to step down, for example. Not always, but that's kind of how we use it. So Kant said it's really how we treat patients. And the outcome is not so consequential, but John Stewart said the end result is the most important. So I use that all the time when it comes to like looking at how we treat patients and say at end of life in the ICU. Do we have them on dialysis, on pressors, on the ventilator, on blood products, and they're not awake and they're not alert, and the family wants us to do CPR, so we do it. And the outcome has been that we've maybe caused suffering during that time, and for no outcome change. But John Stuart Mill might say that it's different. So I mean, again, there's no right or wrong always. It's just how we look at things and how we think about the use of our technology. So I just bring that up because that's part of what our principlism is looking at not just the means sometimes, but the outcome. Now, having said that, when we have patients with cancer and we give them this full blast of radiation and chemo, we make them sick, and we make them feel bad, and we make them immunosuppressed. But the goal then is to be in remission and have good health. So again, sometimes we do cause pain and suffering, but it's the outcome. So autonomy is there. Now we have non-maleficence. This is the do no harm principle. So we don't want to harm our patients. Again, using that oncology example, sometimes we harm them in that way, but it's the outcome that we want. And really, when we look at caring response, it's like doing no harm. So that is the idea. Many of you are legal buffs. It's the idea of negative rights, that we don't have to. You have the freedom to make decisions, and we don't have the right to interfere or impose something on you. So that would be like if you're walking along Lake Michigan and someone jumps in the lake or falls in the lake, and they're going, help, help, help. Under this one, you really wouldn't have an obligation to jump in and help them, right? Because the negative right is to omit, the main principle there is that you weren't the one that pushed them in. So you didn't cause their pain, but you may not have the direct obligation. So, but in our world, it's not harming the patient. So, clinical case for this one, 58-year-old man who was admitted for cirrhosis of the liver. He has advanced full hepatic. His liver is completely not functioning. He doesn't have decisional capacity. He has several adult children that are acting as the legal surrogate because he didn't have a power of attorney and he didn't name somebody specifically. And there's a lot of different possible treatment options. So one of the options that the family was considering is placing the patient on dialysis and full hold. So if his heart should stop or he stopped breathing, they wanted a ventilator, they wanted CPR, they wanted all the medications that would keep his pressure up when he's taking dialysis because his blood pressure was pretty low. Or one of the other options would be just to keep him comfortable and allow him a natural death with his family there in a way that they would want. And the family really wanted to do everything. And by everything, I meant, everything that we could to keep the man alive for as long as possible, physically alive. But the team felt like they were causing him harm by doing that. It's not easy for anybody to have dialysis, let alone someone who's really sick and has liver failure, and their brain is now got all the toxins, and they're encephalopathic, so they really don't know what's going on around them anyway. So would it not be better to not do the harmful things and poke and prod? So that was one of the cases I always think about when we say we don't want to harm this patient. And I think that's a legitimate kind of example. What do you all think about that? It's a pretty basic one, but we can always come back. And I'm mindful, what time do you all have to leave?
We got class at 1:30.
Okay,
So probably 20 after.
I'll go on, then you guys have some more questions. I heard a hand go up. Sorry about that. Okay, so now let's move to beneficence. This is really what we do every day as a clinician, right? Acts of mercy, kindness, charity, an action done to benefit others. I will use my treatment to help the sick according to my ability and judgment. That's part of your Hippocratic Oath. One ought to prevent evil or harm. One ought to remove evil or harm if they can, like cancer. One ought to do or to promote good. Teach them how to take care of themselves. That's really beneficial for them. And so what can you think of that you have done, even as a student, and what you've seen your team do that are of benefit to your patients? Giving them information, maybe, about how to be healthy, diet tips, things like that for their diabetes. What else? Yes.
With the first time we ever got to see patients in sort of a controlled setting, our group, after we were done interviewing, it turned out that the man had recently suffered the death of his father. And so we all got the chance to just encourage him to talk about it and sit and listen to him. And that was a pretty cool chance of getting to do good in terms of giving him an outlet he hadn't had yet.
Perfect. I mean, they don't have to be high tech. Sometimes someone just needs to sit and talk, to somebody. Yes?
Yeah, in a similar setting, I guess this was on Friday, our patient, his main thing was just that he didn't know how to find the care providers who were within his new insurance network, and he didn't want to bother his kids with learning how to use the internet, so we just looked up a bunch of providers near where he lived and wrote down numbers and gave it to him.
Perfect. I mean, these are great examples. And someone else had a hand? Yes? But something so simple as just looking up our technology. A lot of folks don't want to ask. I mean, I know I have to ask my kids all the time how to do it, and I had to ask people today, where's the plug-in? So they may not always ask, but that's our goal in healthcare. This is one of the big principles that we use. So we kind of just went through some clinical case examples, but usually to encourage, to give information, to bring in other support folks. I know our chaplain program here is really good. When I first came here, gosh, I've been here. Are you all, some of you M1s? So you were in that class Friday, right? Okay, good. With the simulated patients. That is so cool. That program is so cool. But you know, it gives you a chance to kind of see these folks and how you deal with real life situations. But I really enjoyed that and give you a chance to talk to them about what it's like and what they need. But sometimes it's just using other resources. So our chaplain program, for example, that's where I was going with that. We have a CPE program, so the clinical chaplains have to get so many hours of continuing ed. And because of that, we have like 10 extra chaplains. And they take call on nights and they answer, they go to all the code, the number 1 emergencies. And it's just that extra person that can just sit and talk. And a lot of times patients really, really need someone to talk to if they don't have family members. And so always think about those resources that can also be a benefit. Chaplains, social workers, you know, there's volunteer services, there's people that can help you take care of these patients, but sometimes they're just really lonely and they just need to talk to somebody. Now the last main principle is justice, and that's looking at how to be fair and equitable in the treatment in light of what is due. So a patient comes in and has a certain kind of pneumonia. We look up, you know, we do the test, we look up the standard treatment for this pneumonia, and that's what we render. If another patient came in with the same organism, we again would do the test, we look at the standard of care, and we should provide them with the same treatment, nothing less, right? So there might be other antibiotics we could use, for example, that may be cheaper and they may be by mouth instead of IV. The patient can do that. But it's looking at treating like cases alike. And Aristotle said, equals must be treated equally, and unequals must be treated unequally. So when a patient comes in and just has a simple pneumonia that can be treated on a regular floor, they shouldn't go to the ICU, right? Because they don't need to be intubated. We can manage their condition in a less intensive way. But if someone comes in with, you know, who's immunosuppressed, maybe has another kind of immunosuppressed, let's say they have HIV or something, and they have pneumonia, same exact pneumonia, they probably need to go to the ICU because they have the same pneumonia, but their cases are different, and we have to treat them different. And you've seen the Ebola stuff on the news about in Texas. They're starting to say, well, maybe he didn't get what he needed, and this and that. And the 2 Americans that came back from Africa got different treatment because they were American and things like that. So those are the things we really do look at, is looking at what is just in our particular cases. And let me tell you, every hospital right now, at least that I know of in Chicago, is hustling to get their Ebola protocol down because nobody wants to be that hospital. I think the next time around. So I've got Ebola emails out the wazoo because we're all like scrambling. Again, this is another thing about justice, looking at a need, contribution. This is from Beecham and Childers, the textbook. And, you know, free market, that's an interesting question too. Our free market really isn't just when it comes to like cases alike, right? So just something to think about. Theories of justice, again, there's lots of different theories looking at justice. Utility, libertarian, communitarian, egalitarian, and a lot of times it's looking at resource allocation, right? There's lots of different ways to look at justice. Market is one way, because in a way you can say that the market is just. It goes up and down, and everybody has the same playing field when they put their money in. Some may have more money, some may have less money, but the market has a way of doing itself with respect to the free market. But there's lots of other theories of justice, and one that we look at closely is looking at the allocation of resources such as healthcare and how we can justly maintain some kind of justice. Last week was ethics week, so, or bioethics and jurisprudence week, and you might have seen that, and some of you may have come to some of the sessions, but we had the medical director for the Indiana State Prison Department. And he was brilliant. He gave us so many good things. We've had Illinois DOT, Department of DOC come and talk to us before, but he was very passionate about how prisoner patients should get the same respect that all the other patients get when they come to a clinic. He goes, you don't always believe everything they say, but when you drill down, they do need the same respect. But he also said that under our current system, prisoners are the only folks in the United States that have a right, a constitutional right. I think it was the 13th Amendment. Someone might look that if you want, but it's really, that was amazing. They have a right. So if they have a right, then something has to be rendered, and it should be in a just way. So if you're interested in theories of justice, there's plenty out there to look at. I think we kind of talked about the ICU case where it's full and we have 2 patients waiting. How do we justly allocate the scarce resources that are our intensive care unit? Or in a pandemic situation, how do you justly triage patients? And we have a pandemic influenza protocol at UIC too. Because we want to make sure that we know what we're doing when something like that happens. It may never happen, but we thought about it. And who's going to get the ventilators? And who's going to, how are we going to triage these folks in a way that's equal and just? Hurricane Katrina, there's several books out there on that if you're interested in just the severity of the situation and the overwhelming need for health care in those situations. And there were some lawsuits related to, was there some euthanasia that went on because they didn't have electricity in some of the places, and how did they handle that? So it's something that's serious, especially when there are huge tragedies that overwhelm the system. So fidelity, they did the last 2 little ones, is faithfulness. Faithfulness. Being faithful to your patients entails meeting the patient's reasonable expectations. They come in from, with a cough and they want you to help them. That's a reasonable expectation. There includes basic respect. Patient has a reason to expect that you will be competent to do what you do. Patient has a reasonable expectation that you will adhere to statements that you have subscribed as a member of the profession. You all have a code of ethics. The American Medical Association has a code of ethics. The Dental Association, Nursing, they all have a code of ethics. We may not know what they say, but we know we have one, and you could look it up if you needed to. But part of it is just being faithful and doing what your patient might expect. But then that means you might have some expectations of them too. And that's okay. But they should expect that you know what you're doing when you do something. And that begs the ethical question of, if this is the first time you're doing, let's say, arterial stick, do you tell the patient it's the first time you're doing it? Because those can hurt, and then they can have complications. Something for you to think about. But I don't have the right answer for that. So it's something to think about and talk about. But faithfulness. And then the next one has to do with veracity, honesty. And, do we ever lie to our patients? Is it okay to lie to your patients? Have you ever lied to your patients? Immanuel Kant gave veracity the most important part. And we have a philosopher here as well that can help us out. But he said you should never tell a lie. The only thing that you should ever do, always, is that which can be universal. So if telling a lie is universal, what would happen if everybody lied every day all over the world?
You would take the opposite as true.
Right. Well, yeah, you would never know, right? We have chaos, and we don't want chaos. So he made the maxim that you should never tell a lie. Well, that's impossible, right? It's impossible. But the question is it okay to ever tell a lie to your patient? I don't know. Yeah.
That's what I was kind of wondering in your first example, where you didn't want to tell the lady
Yeah.
But I felt like asking her if she wanted to know after you had the results is pretty indicative that something's bad.
Yeah,
Because
probably.
like in my head it was gonna be like, oh, we don't have the results yet, but
Yeah.
we want to know once we find out. But that would be a lie probably.
Well, that's a good example. The example that people always bring up is like, well, Mr. Jones went down and had a CT of his abdomen for, his pain. And the doctor said he'd be up at, or she'd be up at 2 o'clock this afternoon because the results would be, and they would explain it to him. Well, it gets to be 2, 2:30, 3, everybody's busy. And the nurse goes in and the patient says, oh, are my test results back? And they are, because she's seen them, or he's seen them. They're in the chart. And what does she say? Yes, but I can't tell you. Yes, they're really bad. No, which would be a lie. Yes.
If the patient wants to know, don't we already know that they want to know, so don't you just tell them?
Well, that's an interesting concept because years and years ago, nurses could never tell test results to patients. And it was for good reason, and we still often don't if we know them, because what happens when you tell this patient, or let's say the student goes in, or the intern who's just covering today, doesn't really know the patient and doesn't know what's going to happen next. So the fear is that if you tell them and you just drop the bomb and say, but I don't know, and they start going, well, what am I going to do? Am I going to have surgery? What is it? Can I get chemo? And you just stand there and go, I don't really know, the doctor will come in and tell you. Then is that worse than just saying, gosh, the doctor? Usually what we say is the doctor will be going to explain all this to you when they get up on the unit, instead of saying, yeah, I know, but I can't tell you. That's a very good question. So yeah, we lie to them, right? But it's for their own benefit, maybe. I mean, if you are that person who can explain some stuff, then that's good. But if it's normal, maybe you could say, oh yeah, Mr. Jones, it came back and it's normal, and the doctor will be in and talk to you. But if it's abnormal and you don't know how to explain it and give them the treatment options, because they're going to freak out right now, I would. So veracity is an interesting sub-note here. But again, I don't always have the right answers. I just help people make some decisions on what's best. We've had cases in pediatrics, for example, and then I'll open it up. And I think that was my example that we're going to come to. Places like we have a 15-year-old female teenager who has osteosarcoma, which is a bad diagnosis, and it has been bad for her. She's had several rounds of chemo. I think it's been a couple years since she was first diagnosed. So she knows the drill. She knows chemo. She knows how she gets sick. She knows all of that. The family is very protective of her. Mom and dad, and she has 3 adult siblings that are over 18. She's the youngest. Current hospitalization shows evidence of metastatic disease, and the oncologist is saying there's no more chemo we can give her. There's no more radiation we can give her. What we have to do right now is palliate her until she dies of her disease. So we have a family meeting because the family, the parents, and the adult siblings are extremely adamant that nobody tells the young girl that she has no more options, no more treatment options, that she's not going to get chemo. They want her to believe that she's going to get some treatment for this because she always has, and she's happy, and she's 15. So the staff is very, very, they're having distress, moral distress, because she has a right to know. She's 15, but she's had this disease for a couple of years. She knows the drill. She knows that she doesn't start getting chemo. In fact, she's been asking the nurses, when are you going to hang my next bag of chemo? I'm ready. I want to get this thing going. And they kind of stepped around like, oh, Dr. So-and-so, she'll be in to help you. So we had a family meeting, and we said, she's 15. She has, she's a teenager. There might be some really important things that she wants to do, or that you might want to do earlier, because she may not live until the spring. When she had like a dance at the school, you may want to have, some kind of ceremony for her early. And we said, no, we don't want to tell her because we're afraid that she'll just give up. She will be so sad. And I think what they were really also saying is that we will be so sad when this happens and there's nothing more. So the doctor was really cool about it. She said, well, we're working on discharge plans. I'm not going to tell her. I'd like you to tell her. And children were like, we will tell her when we're ready. And of course, they weren't ready. every day. They weren't ready. So we had another family meeting, social was there, everybody's there. And finally the doctor said, she is starting to ask questions. Someone may inadvertently just blurt this out. Oh gosh, you're not getting any more chemo. Didn't the doctor tell you? And then that would be awful. They wanted to explain it to her in a kind of a controlled environment where they had people to support her there, family. So the family hadn't said anything to her, so finally the doctor said, wisely, she said, she's starting to ask me some questions. She goes, if she asks me any questions, I will not lie to her. I will tell her the truth, because I'm not going to lie to her. She's been my patient for 2 years. She deserves it. So then the family actually did go in and say something to her, because she was going to be transferred to either hospice or go home. And she wasn't going to get rehab. She wasn't going to get any more chemo. So that was a really very, very difficult case. And what they played, the card they played was that she is not an adult. We are the decision makers for her. And we say no. And that's our right as a parent. So that's that fine line between these older folks, these older teens, that are pretty savvy about their own health. And they have ideas on what they want and don't want. So that was one of the cases that has stood out in my mind about lying. She said, I will not lie. So the summary is that bioethics serves as a way to analyze issues, helps us think about things in a different way. Just because we can, should we? And sometimes we have to help our families kind of move into that thing. Patients don't have a right, or families don't have a right to ask for treatment that isn't an option. Okay? So, for example, a patient comes in, has some chest pain, they need to do a cardiac cath. They said, I really want to be on a transplant list, just transplant me. I mean, that's an absurd example. But, again, they don't have the right to ask for certain antibiotic or certain drugs if it's not the standard of care. But it's having that conversation that helps us get to there. And there's a lot of folks that can help us make those decisions and talk to families. And again, like I said, you have human resources. You have students, you have consultants, you have social workers, you have your APNs on the units, the chaplains, ethicists, and many of our clinicians, we see the same thing over and over again, so we become very jaded. Because the main thing I get when people call me, especially from the ICUs, because they've had conversations over and over and over about, let's say, end of life or treatment decisions, about, very serious treatments. And what I always hear is the family doesn't get it, the patient doesn't get it. So, I know that can happen, but I know that usually when I go in and talk to them in a private area, they do get it. They just are having a real hard time managing. And so we can bring in those folks that can help. Because you all are going to be extremely busy if you're not already on the units. So pull in those folks that can help you and help make it a good transition for the patient and the family. So, any questions in the time we have left? I appreciate your being here.
So you mentioned something about declaring the patient a mature minor. I take it that goes along with if the child is an emancipated minor, but
yes.
Can a child that's not an emancipated minor be declared a mature minor, and how does that work?
That's a very good question. So in Illinois, again, when you're 18, automatically you have all the wisdom and the ability to make all those great decisions, then you can. So go for it. If you're not 18 and you haven't been declared emancipated by the court, so if let's say I'm 17, I moved out of my house, I have my own apartment, I'm working, I can go to a judge and say, I'm able to maintain my own space, I have a job, I wish to be declared emancipated so I can get a loan, I can sign my own papers. That's rare, but it does happen. The other thing, so that's an emancipated minor by the courts. In Illinois, if you are a teenager who's pregnant, no matter how old you are now emancipated for yourself and for your child at the point of delivery, or in the law it says a parent. So a lot of these teenage boys don't know that they're parents, so they aren't able to exercise their emancipation. But there's no obligation for us to find these people. So basically, if they come in and there's certain other rules in the ED for sexually transmitted diseases and alcohol and drug abuse, where they can get treatment without consent of a parent, those are going to be something we're going to see every day. So for the most part, if they're 18, they're emancipated and sign their own consent. We do, in research, you're going to see a lot of assent. So usually from about 11 years on up, part of the protocol will ask for assent. And that's when no means no. They don't want to be part of our research, even if the parents want them to. If they say no, that means no. Doesn't mean that we're going to try not to help them understand things better, but parents love their kids, and when there's a research protocol, especially for chemo and things like that, those are last-ditch efforts, and they want their kid to be on that, because research shows they live 6 months longer than those that aren't on protocol. But again, that's that's something, what I always tell people, if you don't know an answer, ask me. If I don't know the answer, I will get it for you, and I will let you know. So I have a pretty good relationship with our legal counsel, but if I just gave you the phone number to Mike Woods and our legal counsel, that would be horrible. I'll make that call, I'll hook you guys up. So, again, thank you. I'll stay out here for a little bit.